Hi, everybody. A little hot mint tea. It is what? It's October 28th. Can you believe that? Um, I am actually broadcasting to you today from the Facebook page of Second Opinion, and I am delighted to say that I am now the host of Second Opinion with Joan London on all PBS stations. That'll be premiering in January. But until then, working up to that point, we're going to be doing some regular Facebook Lives. We want to know what you're thinking. We want to know what questions you have, what health questions you have, because we'll get experts to talk to. I've got a great one for you today. But first of all, this weekend is Halloween. Can you believe it's Halloween already? So let's talk about this for a minute, because I'm a mom. I have teenagers. They really aren't into the like going around from house to house and getting the candy anymore. But a lot of you women out there have little kids. So the Centers for Disease Control, let's see what they say. They are advising how to avoid high-risk activities, such as hay rides. For anybody that's got a hay ride, they pop up all over though on Halloween, but they say this is not a good idea. And they actually say the traditional trick-or-treating is not a good idea. But certainly make sure that not only your child wears a mask, but that you wear a mask. Indoor costume parties. Now, that's where you get into my teenage kids. Remember, I've got 4 teenagers in high school right now, and they tend to do that. They tend to start going inside when it's rainy out. Haven't looked at the Sunday prediction. They say instead, maybe decorate your house, which of course most people do before Halloween. Have a Halloween costume contest online. I don't know. And decorate pumpkins. So my daughter, Lindsay, she and her kids, they decorated all these pumpkins and they put them out on the front porch. And we have a plethora of chipmunks and squirrels in our area. I don't know about you. I'm looking for people to come in here and give comments. And I don't know where you live, but in this area, and I Googled it to find out, why are there so many more squirrels? And it seems to be that we're in for a very rough winter. That's what it's saying, that we're going to have such cold weather and so much more snow than usual, that the squirrels are out eating more than usual so they can fatten up. I guess that's kind of what we all did during quarantine. We fattened up a little bit. So just remember that on this Sunday, that we are going to be, I'm not seeing any of the comments yet, so that's what I'm looking for, that we are going to have to be extra careful. There are some, I don't know if it's states, but there are many cities around the country, and I think maybe a couple of states that have banned Halloween. So you'll have to check. And the other thing that's recommended by the CDC is that if you want to go online, and it's a government, if you just Google how much coronavirus in my area and put your zip code, that you can track if it's bad in your area. All right, so I am going to share somebody very special with you today. It is still October, so that means it's still Breast Cancer Awareness Month. And so I want to talk a little bit more while we have this opportunity. Not that breast cancer goes away after October 30th, let's remember that. But I think it's great that we have this month where we really focus on it and we really kind of just shine that light on it and remind everybody what they need to be doing to keep themselves safe, and also to let everyone know about the incredible research that's going on and a lot of the new treatments that are available. So I want you to meet Dr. Elizabeth Mittendorf. Now, let me tell you a little bit about her first. She is one of the investigators, I should say, with BCRF, which is an organization that I do a lot of work with, the Breast Cancer Research Foundation. It's the #1 rated breast cancer foundation in the world, meaning that they give more of the dollar that you donate to actual research hours than any other breast cancer organization. She's a professor of surgery at Harvard Medical School. She is the director of the Breast Immuno-Oncology program at Dana-Farber Cancer Institute. And you know, I've had a number of people, Dr. Judy Farber, I believe, recently from Dana-Farber. She's also the co-leader of the breast program at Dana-Farber Harvard Cancer Center. She's also with the Brigham and Women's Hospital. So let's have Dr. Mittendorf join me now so that I can let you meet her. Hi, how are you, doctor?
Hi, Joan. It's great to see you. I'm doing well. Thank you.
You know, I had the opportunity. There was just recently a huge BCRF annual function that usually we're all at the Hilton in New York and we're all dressed in hot pink and we all get up and they bring in, I think it's 267 researchers from around the globe who are all funded by BCRF research funding. It's really quite remarkable. And we didn't get that this year, but they had a huge forum with all of the doctors and researchers who get grants. And then they also had a little breakout session. And the breakouts were by table. And I'm very fortunate that I was at Leonard Lauder's table because, of course, his late wife, Evelyn Lauder, is the one who started Breast Cancer Research Foundation. So I got to ask questions and hear all about recent research from you and a few other of the top doctors. So I wanted to share you with all of the people who follow me on Facebook. But before I ask you about what's the newest and latest thing, can you just share a little bit of your story and what got you into your field?
I can. I like to think I have an interesting story. So after going to Duke University as an undergrad, I went to medical school at Case Western, and I did so on an Air Force scholarship. So after I finished my medical school and surgical training, I had an active duty commitment, which my second day of active duty was actually September 11th of 2001. And I happened to be stationed in the DC area at the Air Force base there. And as we can all recall, that was obviously a dramatic day, which defined a dramatic period of service for me in the military. And I had the opportunity, as the Army was deploying their surgeons in support of Operation Enduring Freedom and Iraqi Freedom, to backfill into Walter Reed, which many may know is one of the major medical centers in the Department of Defense. And at Walter Reed, one of the privileges I had was to work in their breast center. And we got to care for a number of patients, not necessarily active duty folks, but their wives as retirees and all. And one of the women that I cared for there, I'll never forget her. She was, such a kind person who came to the center with what we call a chest wall recurrence. So she'd been treated for breast cancer 15 years prior, and came back now with a small nodule, which she thought, this is probably nothing. It's just a little bump. And in fact, it was recurrent cancer. Wow. And, unfortunately, she ended up progressing and ultimately succumbed to her disease. But in the meantime, she really inspired my thinking about breast cancer, because I couldn't help but think at that time, what happened? I mean, she's been disease-free for 15 years. Wow. And my thoughts turned to, I think her immune system failed her. Like, why did our immune system not take care of this? And in fact, as I think you and I will spend some time discussing, that really informed the direction that my research went, and hopefully is helping to contribute to advancements and improvements in how we're caring for women with breast cancer.
So immunotherapy, I'm sure it was a thing, but it wasn't considered one of my options.
Right.
I'm sure it was being researched, but when I was diagnosed with stage 2 triple negative breast cancer in June of 2014, there was no targeted treatment at the time for that kind of breast cancer. And so what I had to do is I had to take aggressive chemotherapy and radiation and surgery. So I'm not that familiar with immunotherapy. Before we talk about why it's now an option for breast cancer, exactly what is it?
Right. So immunotherapy is treatment that's designed to actually address your immune system more than attack the tumor. So what it does is it basically leverages your immune system to do its job, which is to recognize things that are foreign, attack, and destroy. And if we think about a tumor, what is it if it's not foreign? So a tumor usually develops because normal cells become abnormal, and they become abnormal as we get mutations. And when you have mutations in your normal cells, your normal proteins, that's exactly what the immune system recognizes. And so immunotherapy is treatment that's designed to treat the immune system to recognize tumors as foreign, attack, and destroy. And to your point, when you were treated in 2014, we were using immunotherapy in other histologies, so other types of cancer. So it actually had its initial successes in melanoma and lung cancer. And if we think about melanoma and lung cancer, broadly speaking, we would suggest they're due to UV exposure in the case of melanoma and tobacco in the case of lung cancer.
Yeah.
You can see where those two carcinogens would cause mutations. And so for a while, we thought that immunotherapy might only work in tumors that were caused by such mutations. But fortunately, we've evolved in our basic knowledge of the immune system, basic knowledge of how tumors are or are not recognized by the immune system, and basic knowledge about the immunogenicity of tumors, so that now we've figured out how to apply it to other tumor types like breast cancer.
So is that why the initial trials that were investigating immunotherapy use in breast cancer didn't seem as promising because of that difference?
Yeah, so the type of immunotherapy that is the furthest along and is used to treat the most patients today in, I was going to say the US, but throughout the world, are therapies that work by targeting what are called T cells. So I've always considered T cells as the soldiers of your immune system. So those are the ones that can see things that are abnormal, again, attack and destroy.
Like the fighter cells, right?
Like the fighter cells, exactly right. And so if you look under the microscope at melanoma or lung cancer, there's a lot of purple dots, and those purple dots are those immune cells. And so what immunotherapy, the type we're talking about, which is also called checkpoint blockade, those immune cells, those T cells, when they're activated, believe it or not, they actually put up their own brakes. And that kind of makes sense if your immune response is going against the flu or if you've cut yourself and have a scratch. But if your immune response is against your cancer, you do not want those brakes activated. And so, in fact, this immunotherapy, this checkpoint blockade, works by taking the brakes off. So as I just suggested, melanoma and lung cancer, a lot of those T cells with their brakes on, so the immunotherapy took the brakes off. With breast cancer, when you look under the microscope, you don't see a lot of those purple dots because there's not a lot of immune cells there to start with. And so the thought is, if there's no immune cells there, what would you be taking the brakes off of? So what it required in breast cancer were trials that you kind of alluded to, initial studies looking at the checkpoint blockade that unfortunately didn't benefit enough patients. And what we've learned in breast cancer is you've got to give something in combination with that therapy in order to stimulate an immune response, and then use the checkpoint blockade to take the brakes off. And so in breast cancer, what we found where our successes are is in giving chemotherapy first, causing that to stimulate something of an immune response, and then using the checkpoint blockade. So that's where we've had our success. So about a year and a half ago now, the Food and Drug Administration approved the first immunotherapy regimen, and it's actually for patients with metastatic triple negative breast cancer.
Oh, fantastic.
To your point, triple negative doesn't have any of the standard targets that we'd previously thought of in breast cancer, but now the immune system's a target for triple negative. And so we now use that as first-line therapy. I'm really excited that in the 18 months since that time, and particularly in this last year, there's been another trial looking at another form of this checkpoint blockade that showed exactly the same benefit, so confirmatory. And then this past year, we've had 2 trials that suggest, this might actually work really well in our early disease patients, not the metastatic patients. So, Joan, if you were diagnosed in 2021, you may actually have been advised to take checkpoint blockade prior to your surgery.
Well, we did what was then considered somewhat of a new approach. It's usually you do your ACT, you do surgery first, and then you take that chemo and then do surgery. But my stage 2 triple negative tumor was way back against my chest wall. I never would have felt it, I don't think. And fortunately, after having a clean 3D mammogram that day, clean, I then walked across the hall and had an ultrasound, and they found it. However, I chose to go with a new regimen, which was to do my chemo first.
Yep.
So I did Taxol and I added carboplatin, which I hear a lot of women are now doing. And I had almost a complete pathologic response even before taking AC. It wasn't complete. So I went ahead and took AC. But by that time, tumors were almost completely gone, and my surgery was a much smaller surgery, consequently. So I didn't have to go through all those multiple, surgeries of breast reconstruction, which I felt very fortunate that I didn't have to. So, and the other reason why they wanted me to do the chemo first was so that they could understand the response of the tumor, right? You want to explain that? Because a lot of women are having it done in that. And then where does immunotherapy come in? Do you still do the chemo to some degree, and then at a very early stage in your regimen?
Yeah, so you may not recall this, but we met several years ago at the Miami Breast Cancer Conference. I was one of the conference organizers, and we convinced you to come be our keynote speaker. And just so I'm sure folks here can imagine, the room was quiet as you told your compelling story, and then erupted in applause. So I thank you for sharing your story at that time, and again with us today. So you're exactly right. What we've learned with this triple negative breast cancer is, in fact, if we give the chemotherapy first, it's almost like doing a biologic stress test. It allows us as your providers to know if this is a tumor that's sensitive to chemotherapy. And I'm thrilled to hear that you had such a nice pathologic response, because we know that the response that we see when we do your surgery correlates with your prognosis. And so I'm happy for you that yours is outstanding.
Yeah.
So when we talk about a pathologic complete response, it means that after the chemotherapy, if I, as your breast cancer surgeon, perform a lumpectomy and lymph node surgery, and the pathologist looks at it under the microscope and doesn't see any residual cancer, you have a fantastic prognosis. And in fact, getting to tie the immunotherapy in, the 2 trials I referred to that have been reported this year shows that if we add immunotherapy to that chemotherapy, to include a chemotherapy regimen that looks just like what you received, that rate of pathologic complete response increases by almost 20%.
Wow.
And if the data holds with immunotherapy as it holds with chemotherapy, that increase in pathologic response will translate into improvements in survival. Now, obviously, we will continue to follow patients for years and years to come to demonstrate that. But we in the breast cancer field believe that if you increase that PCR rate, the pathologic complete response rate, it'll translate into improved survival. And so that's really exciting. And then the other thing I would comment on, I'm a surgeon, but I actually don't get to talk about surgery too often. So the point you made is a really important one. When we first started giving the chemotherapy before surgery, it was to do what you just described. Take women who otherwise would have required a mastectomy and now allow them to preserve their breast. And the other thing we know that it does from the surgical approach is that instead of having to remove all of the lymph nodes from the axilla, which is just a fancy doctor word for armpit, we can now selectively sample them and demonstrate that there's no tumor cells there, leaving the remaining lymph nodes, which decreases the side effects that women have from the surgical management of their breast cancer. So doing the treatment before the surgery has really revolutionized the way we take care of triple negative breast cancer and HER2 positive breast cancer as well.
Well, I know at the time I went for a second opinion, and I always say the problem with the second opinion is you actually get a second opinion. And then what do? You have to, it's kind of like they lob it back over onto your side of the court and you have to decide. But I felt that was the latest and greatest. And every doctor I've talked to since then said, you made the right decision. That's almost becoming something, the wonderful thing about breast cancer treatment now is the personalization of it.
Okay.
The fact that you can take a look at that tumor and decide what's going to work and what's not going to work. I want to just take one question. I don't know if this is something we can answer, but she says, I have 2 cysts that were seen on a breast ultrasound last year, seen again this year in a mammogram. Shouldn't I be getting a needle biopsy? Now, the thing she's not telling us, of course, is if she has very dense breast tissue.
Yeah.
because that sometimes you can't see it on a mammogram because everything shows up white, the cancer and the tissue.
Yeah, so I would preface my comments by suggesting that it's not appropriate for me to be offering a medical opinion through this forum, not knowing anything about this kind patient, her age, her prior imaging, doing the exam. Having said that, what I would like to reassure folks is that if your imaging suggests that this is a simple cyst, and ultrasound is very good at doing that, then that's a benign condition. You really don't need to do anything. You can aspirate it if you have symptoms. If you have a complex cyst, then that might require further intervention. But a simple cyst is a benign condition. And if I could just, and again, I apologize for not having been asked a question that I'm answering, but I would like to suggest that during the COVID pandemic, we as professional societies acknowledged that it was appropriate to delay mammographic screening given the risk benefits that we were trying to contend with what our healthcare system was going through. But today, October 28th of 2020, I would encourage folks to get back in for their routine screening. Healthcare systems are safe and that screening is important. And what we're beginning to see with our patients at the Dana-Farber Brigham and Women's Cancer Center and our colleagues across town at the Mass General Hospital is that we're starting to see patients getting mammograms and the cancers that are being diagnosed a little bit larger than they were pre-COVID. Yeah. And so I just wanted to use this opportunity to suggest that, we still recommend yearly mammograms and screening mammograms are safe.
So everybody, and I remember reading in some women's magazine and it had an article on, don't bother doing your self-exams. I was like, whoa, wait, what? I hear from more women all the time that they go in for, in fact, my co-author on Had I Known, which was my memoir of survival, she went in for, because of doing the book with me, she went in and had her mammogram. And by the way, the woman said, she said to the woman when she went in for the mammogram, I really want to find out about my breast density. If I want to find out if I have dense tissue, because of course, I didn't know anything about dense tissue until after I got diagnosed. I found out that I should have known that I needed that ultrasound. I just found it out by luck of the draw. I was sent on a story to interview Dr. Susan Love. And we were kind of chit-chatting, and Susan, she's like, "You do get your mammograms, don't you, Miss London?" And I said, "Yeah, but they're always so nerve-wracking because I'm the one that they're always calling back in for more pictures." And you freak out when you hear that. Yeah. But they would always say the same thing to me. No, we didn't see anything bad. We can just hardly see anything at all because you have such dense breast tissue. And with that, Dr. Love said, well, then you need to get an ancillary test. When you go back, ask your doctor for that script. And so I did. And if I hadn't have gone on that interview that day, I'm telling you, Beth, I would not have known to get an ultrasound. And I had that clean mammogram, 3D. So I've just felt compelled to go out there and tell as much of the female world as possible that they need to know their breast density.
Yeah, and as you know, there are a number of states that have legislation that requires that the breast density be reported in that mammogram report. And what it should prompt is the conversation you're suggesting, which is between the physician and the patient to discuss what other modalities might be employed to further assess the breast tissue to make certain that there's nothing in there. And that's another area that's really exciting to me is some of the advances being made in our imaging technologies, contrast enhanced mammography as a nice example. So mammograms aren't perfect. They're what we have and they're pretty darn good. And so I would encourage folks to get their mammogram, but know that we as a community are working hard to get better.
And so let's talk now more about immunotherapy, because what have been you talked about some of the really exciting findings the other day when we were just talking related to now the use of immunotherapy in breast cancer.
Yeah, so the excitement is and I will say, when I started in this field, It was when people thought there was no way that we'd be able to leverage the immune system to fight cancer. And so I've liked to suggest that I was immunotherapy before it was cool.
Yeah.
But I have said for a long time, and I do believe this, that by the time I retire, and I still have a ways to go, I anticipate that every breast cancer patient will benefit from some form of therapy that either stimulates or supports their immune system to help them in their fight against cancer. And our initial successes have been in patients with metastatic triple negative breast cancer, but only in metastatic triple negative breast cancer that expresses a certain marker. So it's called PD-L1. So that's a whole nother story we could talk about. Is triple negative breast cancer probably isn't one type. It's probably 7 or 8 types of different cancer.
Yeah.
But that means there's a lot of patients who have triple negative breast cancer that doesn't express PD-L1. It's expressed in about 45%, who we need to keep finding other strategies to enhance their immune system. And as you're aware, triple negative breast cancer only accounts for 10 to 15% of our breast cancer diagnoses. So what is the opportunity to use the immune system in HER2 positive breast cancer?
Yeah.
I would actually, so I'm sure, Joan, you've heard of the drug Herceptin before.
Sure, absolutely.
So for everybody, yeah, I mean, that was talk about a game changer.
Yeah.
I mean, that revolutionized the care. In fact, I, as a provider, used to tell patients with HER2 positive breast cancer, I'm sorry, that HER2 expression really portends a poor prognosis. And now I say, I am so glad you're, well, I mean, I'm glad that you have breast cancer, but since you have it, I'm glad that it expresses HER2 because we have therapies that'll target it. I think one thing that a lot of people didn't know and are coming to realize is that one of the major mechanisms of action of Herceptin is actually through the immune system. And so I contend that maybe we've been using immunotherapy for HER2 positive breast cancer for quite a while. But then, of course, the most common type of breast cancer is the hormone receptor positive, which also people might hear it called estrogen receptor positive.
Yeah.
And if you look at those tumors under the microscope, they are what we call an immune desert. They're immunologically cold. There's almost no immune response. And so there's a lot of work ongoing, and we're doing quite a bit of it at Dana-Farber to figure out why does that estrogen receptor positive breast cancer hide so well from the immune system, and what can we do to make it visible to the immune system? So there are so many things ongoing, and we've talked about in the metastatic setting. I expressed to you my enthusiasm of starting to give it earlier in disease to benefit patients. And then, of course, well, my initial work in the field was actually in vaccines. And we know what vaccines are typically designed to do, right? They're designed to prevent infectious disease. I still, in the back of my mind, have one of my goals to continue working towards a breast cancer vaccine that would prevent the disease from ever occurring. So we've got a lot of work to do, but there's so many opportunity, and the right immunotherapy will be determined by the individual patient, their specific tumor, and their stage of disease.
I was just going to ask if there was a way that you could identify those women in which, because of whatever breast cancer they have, that you know that they'll respond.
Right. So as of what you're driving at, and what we call in our field is biomarkers.
Okay.
And so ultimately, so as an example, HER2 is a biomarker to suggest that you're going to respond to the Herceptin drug we've been talking about. Estrogen receptor is actually a biomarker to suggest you're going to respond to endocrine therapy. This PD-L1 that I talked about, it's kind of an interesting story. It appears to be a biomarker for the metastatic patients, but fortunately for the triple negative early patients, the PD-L1 status doesn't seem to matter. They're responding to this drug, increasing that pathologic complete response rate. And that probably speaks to the difference in the immune response that's in a metastatic setting versus a very early setting. So I guess where I'm going with all of this, one of the other things that I feel is our responsibility in the field, because these drugs come with some toxicity, and maybe we could talk about that as well, we have a responsibility to try to find these biomarkers so that we know who's going to respond. And we may even be able to find biomarkers of toxicity so that we can provide supportive care to prevent those toxicities. And the science is there. We're getting there. We're going to be able to find these biomarkers so that we know who's going to respond how, who's going to have toxicity, and who we need to have other strategies for.
I mean, it's so incredibly exciting. Now, a few people have just asked questions, and they're kind of right in where you are right now in the discussion. Someone's just asking about the correlation between neutropenia and cancer. I know sometimes my white blood cell count got down so low my doctors were concerned about febrile neutropenia. So that's when you add immunotherapy, are you now more at risk of neutropenia?
No, actually, immunotherapy is not going to cause neutropenia, but it's actually a very insightful question for other reasons. And that is, when we give chemotherapy, one of the things that it does is it can cause neutropenia, meaning a decrease in your white blood cell count. So another thing, that some of the other toxicities that are due to chemotherapy cause us to give steroids. And so actually steroids can impair the immune response. So we do a lot of work trying to figure out if you can pair immunotherapy with chemotherapy if you have to administer steroids. But to get to the individual's question, there is some data that suggests that there may be a correlation between baseline neutropenia, not neutropenia induced by chemotherapy, that could predispose somebody to cancer, but it's a very limited data set. And so not a lot of conclusions to be drawn yet, but something that probably warrants a bit further investigation.
Interestingly, Tammy Lewis says, I have dense breasts and my tumor was found by an ultrasound, just like me, because I had dense breasts. It was the ultrasound that saw it. She says, my daughter has dense breasts. So is this inherited? I don't know that. Is dense tissue?
You know, no, I don't really think that it's inherited. It's that and what I say to my patients is when we're younger, our breast tissue is very dense. And as you already pointed out, what that means when we're doing a mammogram, dense breast tissue, and again, what I say to my patients, remember when you were a bit younger and you had perky breasts, the dense breast tissue shows up white. A cancer would show up white, so it hides. Yeah. But as we get older and the dense breast elements get replaced by fatty elements, we get a little bit of a droop. There's a doctor word for that called ptosis. And that's when the mammogram...
We call it droopy boobs.
Yeah, so droopy boobs, but doctor term would be ptosis, spelled with a P actually, P-T-O-S-I-S. But that's when your mammograms actually become more effective, because then the contrast between the fat, which shows up black on a mammogram, and the tumor cells, which show up white, is more distinct.
So also, well, this one you already really answered. Are there any advances in immunotherapies for the hormone positive cancers, which you spoke to, estrogen positive and also HER2? And what's the other one? Progesterone positive. Those are all the longer growing cancers, correct?
So in general, the estrogen receptor and progesterone receptor tumors, and you can put ER and PR together as being hormone receptor positive, they tend to be a little bit more slow growing. They have what's called a slower proliferation rate, but that's not always true. There are plenty of ER, PR positive tumors that in fact proliferate quite quickly. And that's a whole nother thing that's revolutionized breast cancer care. I probably used that word a couple times today, but one of the things that's routinely used now in patients who have these hormone receptor positive breast cancer to inform their care is something called the Oncotype recurrence score, or more broadly, these are referred to as genomic assays. And these genomic assays take an individual patient's tumor and look at the genes. And a lot of the genes are looking at exactly what we're talking about, is what is the rate of proliferation of this patient's tumor? And it gives us information. It comes back as a score that's kind of, broadly speaking, can be low risk or high risk. And that helps us determine who with hormone receptor positive breast cancer needs chemotherapy and who doesn't. So when I started in the field, if your tumor was 1 centimeter, you got chemo. Then it was, okay, if you have disease in your lymph nodes, you get chemo. And now we're learning that we can learn a lot more about the biology of an individual patient's tumor and give chemo to those who are going to benefit from it, and not give chemo and just give the endocrine therapy to those who don't need it because their tumors are of that less aggressive type.
To me, this seems like one of the latest, greatest things. Can every woman, or should every woman, or can every woman, when she gets diagnosed, have that tumor looked at to find out what's the best therapy?
So
we're there yet?
We're not quite there yet, but we're darn close. So the assay I just referred to, these genomic assays, they're used for women with earlier stage hormone receptor positive breast cancer. And they don't speak necessarily to genes that we could target, but they give a kind of a compiled score that tells us who needs chemo and who doesn't. But there's another strategy that's employed now frequently in women with metastatic disease, And that is to sequence their entire tumor. So to look at different mutations. And this is a tremendous advance because we know that several of these mutations, I think of them as the Achilles heel of that individual tumor. We can target them therapeutically. And so we are getting closer and closer and closer to that being something. And maybe could actually make an argument that we should routinely be testing patients with metastatic tumors to see what their tumor's Achilles heel is, to either inform the treatment or suggest a clinical trial that they may benefit from that are testing new therapies. And doing that will also advance the knowledge that will help define the new standards for patients to come.
Yeah, especially for those that have metastatic breast cancer.
Okay.
We have Karen Ann is saying, what is neutropenia? So I know you said it's when the white blood cell count goes down, but it's also so that your immune system gets so suppressed that you don't really have, it doesn't have the ability to fight, and you end up in the hospital. And sometimes people would die from an infection that they got because of febrile neutropenia and not the cancer. Now, I know I took Neulasta, which is out by Amgen. I think some other companies may have equivalents now, but Neulasta, when I got it, I went back into the hospital and got a shot. Now, of course, they have Neulasta, I think it's called Onpro, where when you get your chemo, they put this thing on your arm, and at exactly the right point, like, I don't know, 27 hours later, it gives you the Neulasta. And what that is, my description of that is that it's like you send in these little fighters that say, the chemo is killing all the white blood cells. Hurry up, bone marrow. Make a whole bunch more white blood cells. Is that like a real good layman's description?
Yeah, I actually might use that when I talk to my patients. So think about what chemotherapy does. Chemotherapy attacks rapidly dividing cells. It's not very targeted. It's not very discriminatory.
Yeah.
And the reason chemo works in the more aggressive breast cancers is because they divide so fast and chemo gets in the way. If you've got a really slow growing tumor, chemo is not as effective. Back to the story we were just talking about ER. But chemo doesn't discriminate. It also goes after normal cells. So that's what's happening when you get neutropenia. Your blood cells actually are being knocked off by the chemotherapy, just like hopefully your tumor is.
So I have somebody else also asking, and I think this is what you call the neutropenia that is not caused from chemo. Idiopathic neutropenia. So did she hear you right that a person who has idiopathic neutropenia, that could possibly be an alert that you might be higher risk for breast cancer, so you should be on call there?
Yeah, let me try to be very clear about this. There is some data that has been presented that suggests that there might be a relationship, but it's far too early to suggest that it's causative, and far too early to suggest that should prompt any intervention. But it's something that I think warrants further investigation because of the potential impact of that finding. But we have to, as a scientific community, do a lot more work in that field before it's ready for Facebook Live.
Yes, but it's almost unbelievable how much research is being done. And for everybody who's listening who either has metastatic breast cancer or knows someone who does have metastatic breast cancer, I want you to know, because I've heard from so many of you, we need more research in this particular field. And I think Dr. Mittendorf will tell you too. Certainly within the Breast Cancer Research Foundation, a tremendous amount of the money that goes out every year to researchers is now going to metastatic research. I guess you're finding some of the secrets in the study of metastatic breast cancer.
Yeah, and I think that our excitement is driven by our successes. So just in the last couple of years, we've had a number of drugs approved for the treatment of metastatic breast cancer. So there's probably somebody on this call who's had a breast cancer that's due to having a mutation in their BRCA gene, as an example. And we now know that we can use drugs called PARP inhibitors to treat BRCA mutation-associated breast cancer. We've talked about the approval for immunotherapy. In 2020, we had another approval of a drug called sacituzumab, which is what we call an antibody drug conjugate Basically, it's taking an antibody, which is a very targeted therapy, goes straight to the tumor cell. That antibody is linked to chemotherapy, so it delivers the chemotherapy right to the tumor cell instead of giving it systemically with all those side effects. So that was approved this year for use.
Amazing.
Yeah. So we're having successes, and that just, I mean, as one of the investigators, when you have success, obviously it helps to, continue your enthusiasm for the hard work that we're doing.
Well, can you just tell me a little bit about what you hope to achieve through I think it's the Tribute study? I know BCR funds that.
Right.
What's looking for in that study?
Yeah. So just so the folks know what the Tribute study is, for women at one of a couple different sites, it's a multi-center effort. So I'm having fun working with my colleagues across the country, where women who are now getting these immunotherapies as their standard treatment, we are asking them to please allow us to collect biopsy tissue from you before you start the treatment, after you've been on it. And hopefully this won't come up, but if you were to progress, and then also allow us to look in your blood and, believe it or not, get a stool sample from you, because we know that the microbiome may impact response to immunotherapy. And then we're trying to get from them also their clinical data and their imaging, so that we can do what you and I were talking about earlier, do the really deep dive in the science to try to figure out if we have biomarkers, if we can figure out who's going to have toxicity, if we can figure out who, unfortunately, when they progress, what would be a new target that we could go after. And so this is being done in collaboration between the Dana-Farber, Memorial Sloan Kettering, University of Chicago, Cedars-Sinai, University of California at San Francisco, and it's being sponsored by the Breast Cancer Research Foundation in collaboration with the Parker Institute for Cancer Immunotherapy, which I'm incredibly grateful for, not just for the financial support, but for the intellectual support they're providing, because Parker Institute doesn't just think about breast cancer. They think about the immune system and immunotherapy more broadly, and then the Cancer Research Institute. So it's really a team effort. And one of the, I guess, buzzwords that we hear now in 2020 is team science. And I think it's a great example of that.
So what Dr. Mittendorf just said, everybody, is that all this research used to be done in silos, and nobody would share, because everybody was going after, actually also not just the ones who came up with the answers, but they're a good portion of the research funding that's given out. And one of the amazing things that Breast Cancer Research Foundation has done is that they give, tens of millions of dollars to these different entities, but the agreement is that you will all work together.
Right.
That team science, I would have to say, Beth, isn't it one of the absolute keys to how the speed that now we see new kinds of treatments come to life?
Absolutely. So when I started as a very junior investigator, I felt the responsibility to know absolutely everything. I needed to be able to do the experiment, interpret the results, do the statistics, do everything. The science has gone by. It's so fast. It's progressing so fast. There's no way, no matter how dedicated I am, that I could keep up with everything. And so the key to advancing is to put together a team where I have expertise in this and my colleague is a little bit more knowledgeable about this, and we all come together. And it's been really rewarding to me that organizations such as BCRF, such as the Parker Institute, value that and fund that, because it's not the easiest mechanism to get funded, i.e. through a routine grant through, let's say, the National Cancer Institute. So it's that, and to be honest with you, it's a little bit more fun when you're working with a bunch of people as opposed to in your silo, as you described it.
Well, I just heard the excitement of all the different researchers who were on our call the other day, and you could just see that everybody is excited to share information and let everybody get you to the next step, on the next rung on the ladder to finding a vaccine and a cure. But before that, let's end with, what should women be doing? Self-exams. I want them to hear it from the expert.
Yeah. So I actually want to you made a comment about self-exam. The American Cancer Society it's no longer a recommendation for self-exam, but what their recommendation is self-breast awareness. And the only way you have self-breast awareness is if you're doing exams.
Exactly.
And so, I never want for one of my patients who has a breast cancer to feel like somehow it was their fault they didn't catch it. So that self-breast awareness needs to be combined with, we still recommend annual screening with mammogram. we've discussed the limitations of mammograms, but it's what we have and it works pretty well. Making certain that you interpret your mammogram results with your physician, and to your point, asking if any additional testing needs to be done based on a finding of density or something like that.
Mhm.
And then I would also suggest that women need to maintain a healthy lifestyle. So good diet, minimize your alcohol consumption, exercise, live well.
Which, of course, that's a good place to end for everything in general. And everybody who's watching today, please follow us on our Second Opinion with Joan London page. Let us know your comments. Let us know your questions. There's all kinds of information that and videos on that Facebook page on a daily basis. And then we'll know who else you want to have on these Facebook Lives, which we will be doing regularly. So I'll see you again soon. Dr. Mittendorf, thank you for sharing your expertise with us today.
Yeah, thank you.
All right. Bye, everyone.